Welcome everyone. I'm Richard Oehler with the Division of Infectious Diseases with the University of South Florida College of Medicine. And today I'm going to be talking about HIV in the nervous system. This is an important topic, I think, because we're seeing a change in the overall trend towards CNS HIV-associated disease. In the early years of HIV, we saw more uncontrolled involvement of the central nervous system with the HIV virus and the manifestations that would entail from that syndrome. But as we've gotten more effective therapies, we've actually seen some changes in this population. We're seeing patients who are successfully on antiretrovirals live longer, and as a result, they're being exposed to more of the conditions that you would see in people who are uninfected with HIV as they become older: dementia syndrome, CNS vascular disease, and so forth. And we're also seeing more of the complications of therapy because our therapy for HIV infection also can induce CNS side effects. This is a slide showing the risk of neurologic disease in HIV based on different conditions that are known to affect the CNS as a result of HIV infection. And as we can see here, some conditions such as PML are relatively rare, whereas others like the dementia syndromes that occur as a result of HIV infection are much more common. I would also mention here DSP, or distal symmetrical peripheral neuropathy, which is perhaps the most common neurologic condition affecting HIV patients. And as we indicate here, what is not known is how the effects of treatment will affect the incidence and manifestations of these diseases. And to a certain extent, that can vary based on the individual. We're going to start out by talking a little bit about epidemiology. What we do know is that HIV affects the nervous system really at the earliest stages. Prior to the onset of highly active antiretroviral therapy, which we acknowledge started about 1997, it was estimated that up to 70% of HIV-infected patients had a neurologic disease. Now that incidence may have decreased somewhat. And at that time, abnormal neuropathologic findings were found in more than 90% of AIDS patients at autopsy. So CNS disease was extremely common in these patients with clinical AIDS. And as we've said, we're seeing fewer opportunistic infections. In fact, I would ask for a show of hands from the audience here. How many of you have seen a case of CNS toxoplasmosis within the last 2 years? Raise your hand.
And that was a full county, patient non-compliant.
Yeah.
Stopped the antiretrovirals. The hospital came up with follow-up.
Yes, and my colleague, Dr. Anna Velez, is noting that the only case that she's seen recently is in a non-compliant patient or someone not previously treated. But essentially, we've taken a syndrome which was extremely common, we used to see all the time in the pre-heart era, and now one that's, relatively speaking, a footnote that we rarely see except in non-compliant or late diagnosed patients. And we're seeing more dementia, obviously, because patients are living longer. So as we've said, infection of the CNS by the HIV virus occurs really soon after initial infection, and the virus may enter the central nervous system via basically supportive cells, via macrophages. The microglial and perivascular macrophages, these are the support cells in the central nervous system, are secondarily infected. And what happens is you have this inflammatory cascade which induces cellular damage. And it is this damage to the support structures that occurs that may induce the changes thought to result from HIV infection. So the HIV virus doesn't really affect the neurons. It affects the support cells, and these support cells are essential for proper nervous system function. When they are damaged, the pathology results. So we talk about the primary processes that result from the neurologic complications of HIV infections, and the secondary processes. So what are the primary processes? How are they distinct? Well, since I'm podcasting this presentation and I'm trying to cut out the dead space, I'll say that primary processes, of course, are those processes that result directly from the HIV virus infection itself. And secondary processes result from the immune system compromise that results as as a consequence of being infected with the HIV virus. So for our primary processes, we have, for example, HIV dementia, which we'll talk about a little more in a moment. Aseptic meningitis, for instance, mononeuritis multiplex, which can be immune-mediated, but as a direct result of HIV infection. And the secondary processes, of course, tend to be the opportunistic infections that result as a consequence of immune system compromise from HIV, from the HIV virus. So with the different stages of HIV infection, there are also different neurologic complications. When you look at this graph, you see two lines. The hatched line here is the relative burden of neurologic disease, and the solid line is the CD4 count. So if you look very early on within the first phase, the quote-unquote early phase of HIV infection, you see this little spike or bump up in the burden of neurologic disease. These are the consequences that occur really around acute HIV infection. We'll talk about those in a minute. Some of the aseptic meningitis syndromes and other consequences that occur when you have this very high viremia, inflammatory response, and so forth. And when you get into the second phase, this is defined as after seroconversion. That's called the asymptomatic phase. In this phase, you still have a relatively high number of CD4 cells. Your immune system is relatively intact, and so in this period, patients experience really some of the same syndromes that anybody in the general population would experience. Headaches, psychiatric disorders, pain syndromes, so-called endemic syndromes that still occur in the general population. So this is a relatively quiescent phase. It's really when you get into the late phase where your CD4 counts fall below 200, where you get not just the opportunistic conditions, but you also get some of the primary HIV-related syndromes like HIV dementia, and because these patients are frequently on multiple antiretrovirals, you also get treatment-associated side effects. So all that kind of comes to a head here in this late phase. So your burden of neurologic disease escalates, ever higher as your CD4 count approaches its nadir. This is another way of looking at neurologic diseases during the course of HIV infection. And as you can see, of course, you do get some syndromes occurring with a relatively high CD4 count, as we said, around the time of seroconversion. You see here acute aseptic meningitis. And some syndromes, such as chronic aseptic meningitis, herpes radiculopathy, mononeuropathies, and myopathies, can occur really throughout the course of HIV infection. But it's really here in the phase where the CD4 count is less than 200, where you see HIV dementia, the opportunistic infections, cryptococcal meningitis, and DSP. So again, here we're seeing that the vast burden of neurologic disease occurs in the late phase of HIV in the period of time of clinical AIDS. So let's start really early on, and we'll progress forward and talk about, we're going to start out by talking about the primary syndromes. Again, these are primarily related to direct consequences of HIV infection. And acute HIV aseptic meningitis, of course, is a phenomenon that we never want to miss in patients, but can be easily missed if you're not familiar with the clinical picture. And this is the typical picture is typically a young person, anywhere from 16 to 25, who presents with a mononucleosis-like illness, often with a faint erythematous skin rash. But of course, we know with patients who present with acute mono, they do not often present with a clinical picture of an aseptic meningitis. And that's where this picture tends to differ. Patients present with a headache, stiff neck, and photophobia, and when they're taken for a CSF analysis, it reveals a predominance of mononuclear cells, as we can see here. And in this patient, you see a very faint, sort of evanescent, rapidly fleeing rash that occurs. And obviously, if you see a patient like this, it's always a good idea to take a sexual history, assess their HIV risk factors, because obviously, if you have somebody who's acutely seroconverting for HIV, there is a lot you can offer them in terms of treatment, initial treatment, which may mollify or potentially abort their complete manifestations of HIV infection. So it's extremely important to find these patients, offer them therapy initially, and hopefully you'll abort a full HIV infection in them if you can catch them early enough. Yeah. Very good. And the point was made, of course, that there are other manifestations of acute HIV infection, including oral aphthostomatitis, that can result, and that typically this is a board question, and I absolutely agree with that. And so, differentiating among those is very important. Thanks, John. Moving on here to HIV-associated dementia. Again, we're seeing this in increased prevalence because patients are living longer, and so patients progress at a more advanced stage to the period of end-stage HIV if they do manifest it. We are seeing, in some cases, Dr. Velez will agree with me, some of our senior patients who are in their 50s and 60s. In fact, we have followed a patient in our clinics who is in his 80s with HIV infection. So the HIV-associated dementia is a syndrome that we're seeing in increased prevalence. So this goes by the pseudonyms of HIV encephalopathy, AIDS dementia complex, HIV-associated cognitive motor complex. And again, the pathogenesis involves the infection of accessory cell types, like microglial cells, with release of inflammatory cytokines that cause progressive damage to the support system in the brain, leading to dementia syndromes. And this typically produces what's known as a subcortical dementia with subacute cognitive decline, concentration impairment, motor slowing, and eventually a depressed affect. So these are typically the patients that seem somewhat distant, are commonly forgetful about their appointments and about taking their antiretrovirals. Their family members may, in more advanced stages, report that they're frequently withdrawn. Depression is a common sort of co-illness that occurs, and diagnosis is often a clinical one, but there are other elements of the workup that can either rule it out or rule it in. And typically you want to rule out secondary causes with brain imaging and CSF analysis. And if those are not present, then it increases the likelihood that they have a dementia syndrome. Now, what are the treatments for HIV-associated dementia? Typically, we try to make sure that their therapy is adequate and that we're fully suppressing their HIV, and oftentimes that can be helpful. Want to give them supportive treatment for psychiatric problems. Sometimes Ritalin can help with apathy. In the literature I researched today, there's a AIDS clinical trials group study ongoing about this use of selegiline in a transdermal system. So that may offer some benefit, but the jury is still out with that ongoing study. Yeah, the question was about tumor necrosis factor alpha, beta 2 microglobulin, and Diopterin, whether those are quantifiable with an assay, and I'm not aware that they are. There may be some ongoing research in that area, obviously, but typically this is a clinical diagnosis. Yeah. So the beta 2 microglobulin is available as a test in the immunocompromised cancer patients. So you would think perhaps it might be available for this, and I'm not sure about that at this point. So this slide obviously talks about some of the changes that are seen early and late in cognition, motor, and behavioral clinical factors. And you can see that early cognition in HIV dementia, you can get inattention, reduced concentration, forgetfulness, impairment of your slow, fine, and repetitive motion, behavioral apathy, and progressing late, that can lead to global dementia, severe motor impairment to the point of paraplegia, and even mutism. So when we talk about optimizing an antiretroviral regimen in patients with HIV dementia syndromes, we have to think about what antiretrovirals may be effective. And what the data suggests is some of our older antiretrovirals, we have more clinical data. So if you look at the CSF plasma ratio, for example, of drugs like zidovudine, lamivudine, and abacavir, they're very, very good. Also, stavudine it also has a relatively high CSF plasma ratio. Tenofovir, it's listed as unknown. There may be less research there. So there's some element to think that if you want to have relatively high CSF levels of your antiretrovirals, especially your NRTIs, to consider some of the older generation agents. Even you'd think maybe the combination of zidovudine, abacavir, and lamivudine, which is of course available in a single formulation, there may be some argument towards using that, perhaps with a protease inhibitor with a higher CSF plasma ratio like indinavir, or for example, in some cases lopinavir has a recognition. Lopinavir, ritonavir is a recognition of having good CSF activity. But what's kind of a little confusing about this is you don't necessarily have to have high CSF levels for a drug to show some activity in the CSF. So as I said earlier, Kaletra or lopinavir, ritonavir has a recognition of being effective with good CSF activity, but when you look at its levels, it says here it's consistently undetectable. So you don't always have to have high CSF levels with a drug to have good activity in patients with HIV dementia, to have good CNS activity. And also a lot of the newer agents, there's not really effective data. So we don't know, for example, some of the later protease inhibitors like atazanavir or darunavir, or even some of the newer agents like raltegravir or maraviroc, what their CSF activity is. I think in general my feeling would be to have good effective systemic activity in your antiretroviral combination, and that's really perhaps the best thing you can shoot for, because we want to think about the entire patient, the whole physiology of HIV, rather than just concentrating on the CNS. So these are general guidelines. In general, give somebody an effective antiretroviral regimen and they will do well with their CNS disease. Now this is somebody with HIV dementia, and what you can see here is there's cortical atrophy, there is hyperintensity of the white matter, and there's this ventricular enlargement that you see on the MRI. These are all characteristics of HIV dementia. So moving on here, this next syndrome is called HIV-Associated Myelopathy. So this is basically spinal cord disease that's seen with HIV, and it's a chronic disease that progresses very slowly, tends to present late, and can be very prevalent at autopsy. But the diagnostic conundrum is it's really a syndrome that you have to diagnose at autopsy. In other words, you see the characteristic changes in the spinal cord on post-mortem specimen. Until then, it's really more of a clinical diagnosis. Most of these patients get basically neurologic spinal cord disease, such as a dysuria, lower extremity weakness, paresthesias that occur very late in the course of their infection. It's a clinical diagnosis of exclusion. Neuroimaging is often used to exclude other syndromes, CNS lesions, for example, that could cause bowel and bladder dysfunction. And if those are not present, then you would suspect HIV-associated myelopathy or HAM. Treatment is really managing their symptoms. So a lot of the treatment involves managing their bowel and bladder dysfunction. There were some studies in the past involving methionine and IVIG that didn't really pan out. And it also goes by the nickname of vacuolar myelopathy. The reason for that is because when you look at the spinal cord in postmortem, you see all these little vacuoles, these little translucent circles, predominantly at the dorsal and lateral regions of the spinal cord. This is the pathologic manifestation of HIV-associated myelopathy. So again, you'd have to see this in postmortem to be able to confirm the diagnosis. Now, how about distal symmetrical polyneuropathy, or DSP? This is the basically HIV-associated peripheral neuropathy that we see in our patients, and this really is the most common neurologic syndrome in HIV-positive patients. It has a prevalence of at least a third of patients, and in the past it was really associated with the so-called D drugs, of course DDI and D4T, or stavudine and didanosine. But as we've gotten away from these drugs in our primary HIV management, we're noting it more in other drugs that we use in the HIV therapeutic arm, such as dapsone, thalidomide, the anti-tuberculous drugs INH and ethambutol, and even nevirapine has been associated with this as far as the NNRTIs are concerned. There are other neurotoxic medications, but as our patients get older and they get diabetes, they may have alcohol issues, those other comorbidities can also become involved and can contribute to the DSP that's seen in our patients. And the pathogenesis, the same thing we talked about before. You get neuronal damage following macrophage activation and production of these inflammatory cytokines in the peripheral nerves, and that leads to DSP. This can be a severely debilitating syndrome in some patients. You may have seen some of these patients in clinic. Some of them even say, I have a hard time putting socks on in the morning because my feet ache so much, and they're so sensitive to light neurologic input that I get this tingling and burning. I may particularly be susceptible to standing on the subway platform if I'm in a big city where the subway comes and I get all this vibration. It really hurts me. They may have decreased pinprick and temperature sensation in a stocking glove pattern, and later on they may even get some distal muscle weakness. And it's typically in this pattern in the upper and lower extremities with diminished pinprick, and in some cases it's even absent in the peripheral most distal portions of the extremities, and can really affect these patients. In many cases, some patients have told me this is the main reason why I'm unhappy about my HIV disease. I need something done about it. So now diagnosis is primarily clinical. Sometimes nerve conduction studies, quantitative sensory testing can be helpful. Rarely patients progress to skin biopsy to confirm the diagnosis, and this biopsy shows this decreased intraepidermal nerve fiber density that is seen. So how do you treat these patients? Well, you want to be sure and remove underlying causes. This includes neurotoxic agents, nutritional or metabolic abnormalities. Now, obviously, if they are on some of the D drugs, or if they're on a nevirapine and they're experiencing this, obviously you want to consider an alternative regimen, take them off those drugs, and see if it improves. There has been some thought to a recombinant human nerve growth factor and L-carnitine, but these did not really pan out in subsequent clinical experience after some initial small trials. So both of these agents are recombinant human nerve growth factor and L-carnitine are not thought to be clinically relevant. So a lot of the treatment is supportive, and so we look at different categories of drugs useful in DSP, from anticonvulsants, antidepressants, topical agents, nonsteroidals, narcotics, and miscellaneous. And so among the anticonvulsants, gabapentin has been widely used for a long time for these patients, and sometimes it works, sometimes it doesn't. Pregabalin, which goes by the name Lyrica, it's the new fangled treatment for chronic fatigue syndrome that is blasting the airwaves that we are all confronted to. It's also in some studies. Topiramate, which is if I'm not mistaken, a migraine treatment, which is also thought to be useful. And lamotrigine, some patients have had some success with this agent. The antidepressants, the TCA agents, also useful. Topical agents, sometimes when there's severe pain, a lidocaine patch. Capsaicin is thought to sort of mollify the neurologic input there and improve patients. Sometimes the nonsteroidals can be useful. Some of these patients have such severe pain that that narcotics are necessary. So when a patient tells you this pain is really severe, it's debilitating, sometimes we have to progress to using narcotics and opiates in these patients. Now, what are some of the miscellaneous syndromes? Believe it or not, some patients smoke marijuana, and they say that their DSP gets better, which probably explains when I was at the Radiohead concert the other night, I'm sure all the people around me had DSP. So acupuncture is, John Tony knows about that, about the syndrome. About the phenomenon, not, he was not there. Acupuncture, I'll delete that in the post-processing. Acupuncture and prosaptine are also miscellaneous interventions that can be used in DSP. My apologies to you, John, for associating you with the Radiohead concert. Now, these are less common HIV-associated peripheral neuropathies. Now, IDP, inflammatory demyelinating polyneuropathy, and mononeuritis multiplex, they kind of have a split personality. Early on in HIV infection, they're an immune-mediated phenomena, and they often remit spontaneously. Sometimes immune therapies like immunoglobulins and steroids and plasmapheresis can sometimes be helpful. When they occur late, they're usually due to CMV, and they're treated with antivirals. Progressive polyradiculopathy, this is typically a CMV-associated phenomenon that occurs later on in the course of HIV infection. Yeah.
Doesn't CMV also cause pictures, like myelitis on HIV patients?
Yes, and I have a CMV slide, and we'll talk about that in a few minutes. But that's a good point. HIV myopathy. This is muscle disease associated with HIV. It's relatively uncommon, and its pathogenesis is unknown. Now, back in early on in the course of HIV infection, where we did not have a lot of antiretrovirals to offer patients, some of the early treatment modalities involved giving supraphysiologic doses of zidovudine. John Tony remembers this. This he admits to. We were around back then in the day. Yeah. And that's right. So 1,200 milligrams or more of 1,200 milligrams, right? Started at 2,400 milligrams of zidovudine. And many of these patients experience severe myopathy with these supraphysiologic doses of zidovudine. So this used to be more common when higher doses of zidovudine were in vogue. But not as much now. Clinical features: slowly progressive proximal muscle weakness. You get symmetrical weakness of proximal muscle groups, oftentimes elevation of creatinine kinase. EMG findings and muscle biopsy can be helpful in these patients. Some of them get the myopathy is so severe that they'll tell you, I can't even climb these stairs. I can't climb the stairs in my home because my distal muscles are so weak. How do you treat these patients? Well, I mean, if you determine that their antiretrovirals are contributing to the myopathy, obviously changing their antiretroviral regimen or withdrawing NRTIs can be helpful. Sometimes high-dose steroids or IVIG, if it's immune-mediated. Oxandrolone can be helpful in patients who have muscle wasting, the muscle wasting phenomenon, where they need bulking up of their muscles due to the myopathy. This is a sick muscle fiber with other healthy muscle fibers seen in a patient's muscle with HIV myopathy. See some of the basophilic degeneration. You can tell that compared to these others, this is a sick muscle cell. This was a syndrome associated with D4T that was described a few years ago, called acute neuromyopathy and lactic acidosis syndrome. I think this was really at the dawn of the recognition that you could get mitochondrial dysfunction from NRTIs, and this also extends into the phenomenon of muscle, of peripheral nerve disease or disorders due to stavudine. So I think it's a good thing that we're sort of taking our treatments away from stavudine and some of the other NRTIs that cause mitochondrial dysfunction. Well, we're going to move on here and talk about, kind of breeze through some of the secondary processes, since they're more known to us, that cause neurologic HIV disease. It's really the primary processes that kind of stick in our mind as being a little bit more difficult to get your arms around, so to speak. We talked about Toxoplasma encephalitis. This used to be such a common opportunistic infection in the pre-heart era, and my colleagues in the room who remember taking care of these patients who this rolled into the ER a couple times a night, literally, in some of our bigger hospitals. I remember being an intern and resident at Grady Hospital in Atlanta some years ago in the early 90s, where we used to say, another toxoplasmosis case. Take him to the CT scanner. You'd see the characteristic ring-enhancing lesion. Fortunately, this is much decreased in the post-heart era. The prevalence in 1991, when we were commonly doing single agent or dual therapy with dual NRTIs, was considered very advanced back then, was 72%, and we saw maybe some decrease as combination therapy became more in vogue. Now, we know that typically human infection can be acquired basically through exposure to contaminated feces from cats, but you don't have to directly be exposed to the feces. You can be exposed to food products that have been contaminated with the oocyst through exposure to cats or infected material. Most cases in HIV involve reactivation of latent infection. And typically with CNS toxo, you get a very insidious or subacute onset with headache and focal neurologic deficits. You may get hemiparesis, dysphagia, movement disorders, CNN palsies in more advanced disease. It may even progress to confusion and delirium. Now, nowadays we recognize this syndrome, so most patients would be in the CT scanner before they got to this point. But occasionally we see patients where exposure to medical care is delayed, and they present far along in their illness, and we may pick up a case with confusion or delirium. still today, but it's more relatively rare. And this was a common etiology of a seizure syndrome in an undiagnosed HIV patient in back in the day, as they say. So how do you diagnose toxoplasmosis? Well, imaging studies, obviously a CT or MRI, a SPECT or PET scan, or can be helpful in differentiating this from a lymphoma syndrome. Toxoplasma serum IgG again can be helpful to diagnose whether someone has been exposed to toxoplasmosis. Obviously, if they're IgG negative, it decreases the likelihood that their ring-enhancing lesion is due to an infection, rather, more likely to be due to lymphoma. Brain biopsy typically is much less commonly done now. Typically, we treat empirically first, see if their lesion improves, and if it doesn't, then an invasive procedure may be necessary. And this is a CT scan of a patient with and without contrast enhancement, showing the typical ring-enhancing lesion. This is a postmortem specimen of someone with CNS toxo, showing some of the necrosis and in some cases sort of liquefaction that occurs in this disease. Liquefaction, that's a word I haven't used recently. So treatment of toxoplasmosis in immunocompromised patients, pyrimethamine plus sulfadiazine plus folinic acid, and the regimen is shown here.
Richard,
Yeah.
I think most people in the U.S. don't eat raw meat. So how do people acquire toxin? Does it increase the more cats you own, or is that just a minority of stuff? Cleaning litters and petting your cat and getting the fecal oral? Or is meat the number one 99% of all transmission, or we just don't know?
Well, to our podcast audience at home, the question was, which is the most common means of transmission of toxoplasmosis nowadays? Is it through ingestion of contaminated food material, or is it through exposure to cats? And I know that in countries like France, where people are more likely to consume food products that are exposed that are contaminated rather with toxoplasma, the incidence of toxoplasma seroprevalence is much higher. I still think that the majority of people that are exposed are still exposed to contaminated foodstuffs. Really, exposure to infected litter is still not as common, although for pregnant women you still hear that they're supposed to avoid the litter pan if at all possible. And of course, simply touching contaminated litter is not sufficient to become exposed. You really have to touch it and then ingest that material somehow. So it is difficult, but my direct answer is I still think that direct ingestion is the most common means of exposure rather than handling cat litter. So for immunocompromised patients, they still have to be extremely careful about eating foodstuffs that would be exposed to toxoplasma. I'm sure we still get cases where domestic animals may defecate in a agricultural area, and the oocysts may contaminate produce, and then people ingest it. So I think that still occurs.
And rare but possible. I've had several 20 and 30-year-olds, mostly 20s, who get toxo in the eye and nowhere else. And the books say that that's congenital transmission.
Yeah, very interesting.
Like the brain dead torch, it just shows up when you're 20 and you're red.
Yeah, and so there's still some congenital toxoplasmosis that manifests farther along into early adulthood that may be exposed in the peripartum period. Cryptococcal meningitis, we still see this because it continues to be a occasional pathogen of normal competent individuals who may have some subtle defect in their immune system and who may be exposed to Cryptococcus through a variety of different means. But indeed, we see it also in the HIV-infected population, particularly in AIDS patients. And it really is the most common CNS fungal infection in AIDS patients. It has a very high mortality rate. And as we know, Cryptococcus is commonly distributed in the soil, associated with decaying vegetation and bird droppings. This too has an insidious subacute course. Patients may have headache and fever. They may present with meningeal signs, papilledema, cranial nerve palsies, and it's been increasingly recognized that elevated intracranial pressure can very much predict a poor clinical outcome. So managing these patients' intracranial pressure is crucial when you're treating their infection. We see, of course, budding yeast forms on KOH prep. CSF often with relatively normal cell counts. This is, of course, a relatively non-inflammatory CNS infection. Perhaps that's because of the thick capsule, but these patients typically don't manifest a lot of inflammation in their CSF. And here's the narrow budding organisms, the yeast with the thick capsule. This is a silver stain, and this is a postmortem specimen, again showing slightly cloudy leptomeningeal covering here, but we don't see a lot of the thick purulence that we do with acute bacterial meningitis. So this is not a very inflammatory syndrome. So can you see somebody with cryptococcal meningitis with one white cell in their CSF? Absolutely you can. I mean, that's typically what you see in the HIV population. Yeah.
Some of these crypto don't have such a thick capsule,
Mm-hmm.
and on an NDA they can be confused with white cells.
Excellent point. My colleague, Dr. Tony, is saying that you do not have to have a thick capsule in all of the cryptococcal organisms that you see in the CSF, and so they can sometimes be confused with a white blood cell.
The non-encapsulated cryptos will have a negative crypto antigen because that's what gives you the positive.
Good point. And so again, you may not see the crypto organisms with a thick capsule, and those are important for diagnosis. This is a treatment of cryptococcal disease in HIV-positive patients. Again, we have long known, as proven by the mycosis study group, that amphotericin B plus 5-FC is the preferred treatment. And Dr. Pappas, who spoke with us recently from UAB, confirmed that actually patients tend to do better with plain old amphotericin B deoxycholate rather than the liposomal preparation. So we're using that preferentially when possible. And consolidation is, of course, with amphotericin B. Itraconazole may be useful for maintenance. And we can use fluconazole in patients with mild disease. But most people, I think, would use amphotericin B plus 5-FC and then follow that with fluconazole suppression for maintenance. This table is actually a little bit out of date.
And the rationality of adding 5-cytosine is to prevent relapses.
And the rationale is to prevent relapses with 5-FC. Also, I think these patients also get more rapid clearance of their CSF with that combination too. I think that's what Dr. Pappas had indicated. All right, moving on here to progressive multifocal leukoencephalopathy. I always like to say that PML is the one syndrome. It has a very long descriptive name, but the name basically defines the syndrome. So this is a progressive syndrome. It occurs in multiple different loci in the central nervous system, and it's a leukoencephalopathy. Basically, it's a disease of the white matter of the brain. And this is a infectious disease syndrome, of course, caused by the JC virus, a polyoma DNA virus. 90% of the general population is seroprevalent, so it's very common in the environment, very commonly prevalent in the general population. But clinical manifestations occur when you become immunocompromised because the latent infection becomes reactivated. And as I said, you get infection of the myelin-producing cells, the oligodendrocytes. You get demyelination of the parietal occipital white matter. Patients can present with multiple neurologic signs and syndromes and symptoms that can include gait abnormalities, speech impairment, extraocular muscle palsies. Later on, you may get mental status changes. Seizures can occur. And since this is a disorder that occurs in the end stage, patients can progress to death in a matter of weeks to months. This is a person with a PML lesion seen here on their MRI. And again, this is a disease of the subcortical white matter, so you see this necrosis and cavitation here in the white matter. Again, this can be very necrotic on postmortem specimen. This is a myelin stain, and you can see these translucent areas here where the patient's white matter has been demyelinated. And again, I think this is a beautiful descriptive picture of the demyelination that occurs in these patients with PML. Diagnosis is clinical with focal neurologic deficits, abnormal neuroimaging, and a positive CSF PCR for the JC virus. If you have all these things, it's a strongly diagnostic of PML. But I've been familiar with some cases where PML has been diagnosed and the CSF PCR has been negative. So think of this as CSF PCR for JC as a helpful test, but even if it's negative, you can still have PML and still be diagnosed. And sometimes we need to go to a brain biopsy in these patients. Or if they're end stage, they get diagnosed in a postmortem autopsy. Optimized heart is really the optimization of heart is the main treatment for PML. The drugs that have been studied in recent years have included cidofovir, cytarabine, and topotecan, but all of these have not really panned out. Essentially, this is still a syndrome without a viable treatment where we just try to optimize their heart and manage their complications. Yeah.
We've had 3 cases, all in cancer patients. I think all of them had a PCR JC virus negative, CSF, all 3 had brain biopsies, proved very positive. And we treated one with cidofovir, which doesn't prove anything in the literature, is very bad. We treated one with alpha interferon ALL. She survived, and her aphasia, paraplegia improved, not normal. 4 years later, she's still alive. We'd like to publish her case. There's not a lot of those.
That's a very good case.
These people can't get to work, but in case you have someone who's not responding to heart or it's too low to CD4, alpha interferon is your last result.
Very good kid. My colleague Dr. Green indicating in his clinical experience he had treated several immunocompromised cancer patients with PML, and in particular there was an anecdotal case of alpha interferon treatment where the patient survived. So again, some of these things we have very successful anecdotal evidence that they may be helpful, and obviously sometimes it's difficult to go to the clinical trials. Yes, Dr. Tony.
There's several cases of PML associated with, what was the monoclonal that they're using for MS? Talzumab or something like that? No, it wasn't Talzumab. I can find it later. There were a few cases that they backed off of using that drug for MS.
Okay. So again, maybe some of the monoclonal antibody type therapies may have a role as well, but very early on in that category of agents. I see where our time is getting limited here. I'm going to breeze through these last couple. CMV encephalitis. Remember that CMV can affect all levels and all cells within the nervous system. So we can see CMV in a variety of different presentations, as we've seen from progressive polyradiculopathy to mononeuritis multiplex to CMV ventriculitis. Remember, these tend to be patients that are farther along in their HIV. CD4 cell counts much less than 200, obviously. And this is a slide from Mandel's Atlas showing the neurologic effects of CMV infection. My colleague, Dr. Velez, noting before about both the ventriculitis encephalitis associated with CMV infection and also this polyradiculitis that they can get where they get urinary retention, sacral anesthesia, paraparesis, and pain. And CSF findings, they may have a PMN predominance, high protein in the CSF, a low glucose, and they may be CMV PCR positive in their CSF or culture positive even potentially. This is a ventriculitis with CMV and in both a microscopic and post-mortem specimen. How do you diagnose these patients? CSF culture and serology is not really the way to go. You really need to get a CMV PCR of the CSF, which in studies have shown to have a very good sensitivity and specificity potentially. These patients with CMV syndromes are farther along in their HIV infection, so they generally their mortality rate is relatively high. And the drugs that have been shown to have some activity include both ganciclovir and valganciclovir, foscarnet, and cidofovir. But despite all the studies that have been shown, it's still very questionable whether any of these therapies ultimately impact on the clinical outcome. So it's really hard to treat these patients. They tend not to do well, even if you throw cidofovir and foscarnet, or foscarnet plus cidofovir, or any other combination at them. CNS Mycobacterium tuberculosis can present in HIV. Remember that this can include TB meningitis or even a tuberculoma, a CNS mass presenting as a manifestation of TB. And remember cranial nerve palsy as an initial presenting sign. That can be on your boards. This is a very famous slide that is very prominently in every attending's slide set. He looks. He's probably from India, and I believe it said that in the Mandel. And you can see his cranial nerve palsy here. This is also from Mandel Atlas, showing clinical presentation, headache, apathy, behavioral changes, fever, meningismus, and positive PPD being clinical presentations. This is an MRI showing some of the leptomeningeal enhancement that occurs with TB meningitis, and this is a basilar postmortem showing this very gelatinous exudate that is seen with TB meningitis. This can plug the ventricles, and it's one of the reasons why you give prednisone in people with TB meningitis, to alleviate some of the obstruction and the inflammation that occurs there. Opening pressure, CSF WBCs shown in this table, with a low CSF glucose and a relatively high CSF protein. CSF smear and cultures have variable sensitivity in diagnosis, and the one case that I can recall from here where we diagnosed a TB meningitis in an HIV patient, the diagnosis was made with a PCR of the CSF. So don't be afraid to order that test. It is available. Neurosyphilis can present with HIV of a variety of different clinical presentations. I have my colleague Dr. Tony in the audience, who our STD guru, so he can comment on this. Diagnosis is more difficult in HIV patients. And remember that syphilis serology in HIV can be very variable and may either be diagnostically confounding or sometimes helpful. There are many different clinical manifestations of neurosyphilis. Remember the meningovascular syphilis, which may present as a stroke syndrome in a very young person with HIV. Remember the paresis and the tabes dorsalis. The paresis tending to present with more central nervous system CNS manifestations. The tabes dorsalis with more peripheral CNS or peripheral nervous system manifestations, such as bladder disturbances, incontinence, and gait disturbances as well. Clinical features of meningovascular syphilis are shown here. I'll kind of breeze through that in the interest of time. This is a lymphoplasmacytic infiltrate in the sulcus of somebody with meningovascular syphilis. And in closing, other CNS opportunistic infections in HIV that we want to think about can include such things as nocardiosis, aspergillus, strongyloides even, and some of the bacterial syndromes like listeriosis. And you need to think about these as well. CNS lymphoma can commonly be a confounding diagnosis in somebody who may have CNS toxo. They can often present with similar manifestations. How do you tell them apart? Well, oftentimes that goes on to tests like SPECT and PET scans. Patients may present with seizures, global impairment. Really, any HIV patient with fever, night sweats, and weight loss, and a history of prior opportunistic infections should increase your suspicion of CNS lymphoma. And as we've said, we try not to have to progress to brain biopsy if we can differentiate their CNS lymphoma diagnosis by getting toxoserology, by treating for toxo empirically, and by getting SPECT and PET scans potentially. Sometimes a CSF PCR for EBV can support the diagnosis of a CNS lymphoma. This is a patient with a CNS lymphoma. And remember that toxo tends to present with more single lesions, and CNS lymphoma can occur with multiple lesions. That's not always the case, and there's very frequent overlap, so don't go by that as a rationale, but be aware of the pattern there to fortify your diagnosis. Now, we want to think about vascular, nutritional etiologies of HIV neurologic syndromes as we've gotten away from some antiretrovirals like the D drugs. But we still use a lot of efavirenz, but there's an increased recognition of the CNS effects of efavirenz, and they tend to wane with time. So thinking about drugs as a cause of these neurologic syndromes, of course, is also important. It's a lot of ground to cover, but I hope that I've given everyone in the audience an awareness of the neurologic syndromes that can occur in HIV.